Hello, I'm Dr. Marina Serper, Assistant Professor of Medicine at the Perelman School of Medicine in the University of Pennsylvania and the Crescents VA Medical Center in Philadelphia.
Hi, and I'm Dr. David Kaplan, Assistant Professor of Medicine at the University of Pennsylvania and the Crescents VA. On behalf of our co-investigators, the Veterans Outcomes and Cost Associated with Liver Disease Study Group, or VOCAL, we're pleased to discuss our recently published paper entitled Association of Provider, Specialty, and Multidisciplinary Care with Hepatocellular Carcinoma, Treatment and Mortality.
Hepatocellular carcinoma, or HCC, is now the second leading cause of cancer death in the world, while resulting in 35,000 deaths in the U.S. each year. HCC is a complex disease in which treatment depends as much on tumor stage as liver function, with multiple treatment options available based on provider availability and expertise. Given this wide variability in treatment options and treating providers, our group was interested in evaluating the impact of HCC therapy and geographic and provider differences that could affect treatment utilization and survival. We also wanted to evaluate whether multidisciplinary tumor boards improved outcomes, as has been shown in other malignancies.
Most previous data regarding HCC treatment and outcomes to date has been generated from the SEER Medicare Registry, which has limited data on liver disease severity and cancer staging, as well as predominantly includes elderly patients. Other data have been derived from tertiary referral centers, limiting their generalizability. To address these previous limitations, we chose to use the National VA Database, which contains comprehensive diagnostic, laboratory, pharmacy, and procedural codes on a large number of U.S. veterans of various ages diagnosed with liver cancer managed at rural and urban, community-based, and tertiary care sites between 2008 and 2010. We combined administrative data with 100% chart abstraction to confirm the cancer diagnosis, obtain tumor staging information, and identify which types of providers directed liver cancer care.
Of the entire cohort of 3,988 veterans, 2/3 has underlying hepatitis C and half were either current or past alcohol abusers. The majority, 82%, had cirrhosis, nearly half of whom had advanced Child-Pugh B or C disease. With regards to HCC, a total of 36% had early stage, Barcelona Clinic liver cancer stage 0 or A, 32% were stage B, 17% were stage C, and 14% were stage D. A total of 86% were managed at urban hospital systems, while half lived more than 75 miles away from the VA hospital.
We first examined which treatments patients received initially, overall, and stratified by Barcelona stage. Overall, only 15% of patients received initial therapy with curative intent. Even for early stage Barcelona 0 and A patients, only 1/3 received potentially curative therapy as the initial treatment approach, and 20% received no therapy at all. While the latter statistic appears high, it is consistent with previous data from other studies.
Subsequently, we were most interested in which factors were associated with active therapy being administered. Not surprisingly, we found that advanced age, more severe liver disease, poor physical performance status, and more advanced cancer stage were associated with less frequent treatment. Interestingly, we did not find that care in rural VA centers or patient distance affected the receipt of treatment. We did note that care at academically affiliated VAs was associated with a near doubling of treatment rates. Furthermore, a patient seeing multiple specialists, particularly seeing a medical oncologist or surgeon, was associated with higher rates of active therapy.
Some, but not all of the factors associated with receiving HCC therapy also impacted survival. Not surprisingly, all active HCC therapies, except for sorafenib, were associated with improved survival. Seeing a hepatologist within 30 days of a liver cancer diagnosis had the strongest impact on survival, with lesser but still significant impact for seeing an oncologist or surgeon. Finally, evaluation by a formal multidisciplinary tumor board was strongly associated with improved survival.
In summary, we noted deficiencies in the delivery of active and potentially curable therapies in HCC. Receipt of curative therapies conferred the highest survival benefit, while notable geographic and specialist variation was observed in their delivery. Finally, multidisciplinary tumor boards were associated with improved overall survival. In conclusion, future studies should evaluate how health systems may optimally deliver high-quality care in HCC in order to optimize patient outcomes.